Hello, my name is Kayla-Richelle Grieve. I am a registered nurse. I've been a registered nurse for 14 years, and I was a nurse's aide before then, so I've been working in healthcare for um, almost 20 years. So today, everyone is out of town. I'm getting ready to leave for some training, so all I have is my patient here, Ranger. He is, in people years, he's about 48 years old, male. He is, lives a sedentary lifestyle. Um, I'm going to do a thoracic and lung inspection. First, I'm going to observe his thoracic shape, symmetry, and his respiratory effort. So his respiratory effort's a lot better now than it was about 20 minutes ago. He was out in the hot Alabama early summer, late spring weather, ambulating. Um, so I am looking at his thoracic shape, and it looks pretty good right now. He takes even breaths. His sternum is deviated. It's midline. Not much effort. I'm looking for accessory muscle use. Not much, little bit. I don't see any retractions. The only visible abnormalities I do see is under his arms. He's got some fatty tumors. They're benign though. They don't affect him. It's just years of weight gain, and he has been dieting, so everything is within range. Um, he used to run a lot, but about 5 miles every morning, about 4 years ago, but he does not run much. He does not have any small respirations. So I don't feel any tenderness or like crepitus that you would feel in end-stage COPD, but I do have those masses, but they're under his arms. I'm going to go ahead and look again at his chest expansion. You roll over, buddy. It expands just even. Also looking for any visible pulsation, murmurs, thrills that can be felt, like something you would feel over a dialysis port. Also murmurs too. Now I'm feeling for his pulses here, extremities. And then I'm always going to auscultate before I do any type of palpation to listen for any hyperresonance. So I'm going to go ahead and listen to or auscultate over his bronchioles. And what I'm looking for are adventitious breath sounds. Something out of range, anything diminished, any inspiratory or expiratory wheezing, and inflammation as well. His lungs are clear. I'm also going to listen on the posterior aspect as well. Can you take a deep breath for me? He does use some accessory muscles, breathe, but nothing that would indicate any type of distress or respiratory disease. I think his is just BMI related. And so now I'm going to go ahead and listen for any type of turbulent blood flow or valve disease, as well as murmurs. I did check for peripheral pulses, any reduced blood flow. And then over his carotid and jugular areas, I don't see anything that would indicate fluid volume overload. So once I auscultate, then I'm going to go ahead and percuss over cardiac borders as well as his lungs. What I'm listening for are normal S1, S2 sounds that would indicate a closure of the valves. And then to check if there are any extras. It's okay. It's okay. It's okay. Okay. The extra hard sounds would be something like a S3, S4. S3 would be something you would hear in heart failure. And S4 would indicate decreased hypertension or aortic stenosis, and you can hear aortic stenosis too. Pulmonic stenosis, especially people with COPD. And then we're going to listen for murmurs, any type of systolic or diastolic murmur. So come here. My systolic murmurs, it would be your aortic stenosis, mitral regurgitation. Your diastolic murmurs are, I think it's aortic regurgitation, and then also mitral stenosis. You wouldn't have any type of rub, cardiac friction rub, infections, heart failure. So I'm going to go ahead and listen. O2 stats, of course, would be over 90. Well, and then blood pressure, definitely less than 140. So I'm going to go ahead and listen to him. So now I'm going to do the percussing. So I want to percuss over the cardiac margins. I would do a chest x-ray just because of his age and his weight. And I think that his history of running 5 miles a day about 4 years ago would reduce his risk of cardiovascular disease. But I would definitely check that out, as well as echocardiogram. So go ahead and roll over that. There you go. And get him in a position that's comfortable. And then I'm going to percuss with one finger over my middle finger. And what I'm listening for is denser areas that will tell me where the margins are. It makes it a little bit difficult with him because he has a mass under his arm. It is benign. I'm gonna go ahead and listen to his lung sounds too. And I'm also going to look at peripheral pulses as well. In some patients, you're not always going to be able to palpate peripheral pulses. People do say that you can feel them, but in all actuality, individuals with any type of respiratory or cardiovascular disease, it's nearly impossible to feel a pedal pulse. Check the popliteal as well. But yeah, this is Ranger, and I would obtain a chest x-ray, even though I assessed the cardiac margins and I didn't hear any type of stenosis or regurgitation. I would check for cardiomegaly. His lungs are clear. No thrills, and his peripheral pulses, he had the regular rate and rhythm. With the percussion, the only portion that was a little difficult was over where he has the mass under his right axilla. So it does provide an estimate for cardiac margins, but primarily used as for assessing lung resonance. His heart sounds were normal. I heard normal closure of the valves. Nothing sounds like a murmur or stenosis or regurgitation. He doesn't have any signs or symptoms associated with any type of fluid volume overload that you would see in a heart failure patient. That you would hear the S3 heart sound, and then your S4 would be hypertension and aortic stenosis. Systolic murmurs, I didn't hear any, or diastolic. I would also get an ECG to evaluate cardiac rhythm or any type of conduction abnormalities, even though I didn't hear any irregularities, just because this patient has not had a health assessment in some time. I think that that would be a good thing for this patient, as well as a lipid panel. With age and reduction in activity, I think that a lipid panel would be also a good thing for my patient. Thank you.